Hi friends, now we are going to the next topic on neck swellings. So this is a high yield topic for dental exams as well as for PG exams. So there are many swellings in the neck. So I'm going to make it very simple. What are the swellings in the neck? And this topic is taken from Bailey and Lau. Before understanding the swellings in the neck, you should know the triangles in the neck. Okay, let me first make you clear the triangles in the neck. So this is the sternocleidomastoid muscle. Please remember, this is sternocleidomastoid muscle. And this is the midline of neck and this is posterior. So now you can see there are two triangles. This is anterior triangle and this is posterior triangle. So anterior triangle and posterior triangle. So now I'm going to make so many anterior triangles now. So many small anterior triangles I'm going to make now. And now please remember this landmark hyoid bone. This is hyoid bone. Okay, this is hyoid bone. And this is anterior belly of digastric coming here like this. And this is posterior belly of digastric going like this. And this yellow color coated triangle is known as what? So anterior belly of digastric, posterior belly of digastric, and mandible. This triangle is known as digastric triangle. So please don't forget this triangle is known as digastric triangle. Also known as submandibular triangle. So digastric triangle or submandibular triangle is triangle between the mandible, anterior belly of digastric, posterior belly of digastric. Okay, now comes a very important muscle, superior belly of omohyoid. This is superior belly of omohyoid. And this is inferior belly of omohyoid. This is superior belly of omohyoid and this is inferior belly of omohyoid. Now I am going to draw a triangle in a light blue color. See this triangle, light blue color. What is this triangle bounded by? It is bounded by posterior belly of digastric. So please remember, this question is expected question. It is bounded by posterior belly of digastric, superior belly of omohyoid and sternocleidomastoid muscle known as carotid triangle. So carotid triangle boundary is a separate MCQ from anatomy. It is bounded by posterior belly of digastric. So please don't forget it is bounded by posterior belly of digastric, superior belly of omohyoid, and sternocleidomastoid muscle and sternocleidomastoid muscle. So please don't forget posterior belly of digastric, superior belly of omohyoid, sternocleidomastoid muscle together forms the carotid triangle. And this is one important triangle seen anteriorly, muscular triangle. This is muscular triangle. The pink color one is muscular triangle. Seen anteriorly in the front, it is full of the strap muscles. And there is one more triangle that is not seen from this view, that is submental triangle. That is known as submental triangle. Between the two anterior belly of digastrics, we have submental triangle. So in this, the question can come for you from this carotid triangle. Please don't forget, carotid triangle boundaries can be asked as an exam question for you. So carotid body triangle, it's a carotid triangle, don't forget. And similarly, coming to the posterior triangle, we have now two triangles. The superiormost triangle is known as suboccipital triangle. Above the inferior belly of omohyoid, it is suboccipital triangle, and below is known as supraclavicular triangle. It is known as supraclavicular triangle. So anteriorly, we have totally 4 triangles, and posteriorly, we have 2 triangles. So the two posterior triangles are not so important if it is enough if you know as one posterior triangle. So though there are 2 parts, suboccipital and supraclavicular, it is not so essential for your exams. So just remember all these triangle anatomy, because only when you know the anatomy you can identify the swelling seen in each triangle. Now, what is the most common swelling in the neck? So what is the most common swelling in neck? Can you tell me? Even you can have one swelling now. What is it? That is lymph node enlargement. So lymph node enlargement is the most common swelling in the neck. So in any triangle you can get this neck nodes. So neck node is the most common swelling in the neck swellings. Now let me classify the neck swellings in a simpler way for understanding purpose. Neck swellings in carotid triangle. I am going to discuss only carotid triangle swellings and posterior triangle swellings. So in carotid triangle and posterior triangle we have neck swellings. So please remember, carotid triangle, what is the solid swelling, what is the liquid filled swelling, and what is the air filled swelling in the carotid triangle. So I'm just making it for understanding purpose simple. Solid swelling in carotid triangle is known as carotid body tumor. Carotid body tumor. Liquid filled swelling in the carotid triangle is branchial cyst. In the carotid triangle, you get a liquid filled swelling is branchial cyst. Air filled swelling in the carotid triangle is what? Air filled. It is filled with air, that is laryngocele. Laryngocele. In posterior triangle, the solid swelling you get is cervical rib. Cervical rib. Liquid filled swelling is cystic hygroma. Cystic hygroma. And air filled swelling is, what is air filled swelling? You can see posterior to sternocleidomastoid. You have already discussed in esophagus chapter about this topic. We discussed this in esophagus chapter known as pharyngeal pouch, also known as Zenker's diverticulum. Also known as Zenker's diverticulum. I request you to see this topic alone in esophagus chapter. The Zenker's diverticulum alone in esophagus chapter. Other topics I am going to discuss now. So I am going to discuss the 5 important swellings now in this chapter. So please remember, for understanding purpose I make like this. So for easy purpose. So in carotid triangle we get carotid body tumor, branchial cyst, laryngocele. In posterior triangle we get cervical rib over here, or you can get a pharyngeal pouch here, or you can get a cystic hygroma in this place. Now let us start discussing one by one. The first one is carotid body tumor. Carotid body tumor. So carotid body, what is carotid body? Physiologically, what is carotid body? Carotid body is a chemoreceptor. Please remember, it is a chemoreceptor. Where is it seen? It is seen exactly at the bifurcation of, common carotid artery. This is the external carotid artery. This is going to be the internal carotid artery. So internal carotid artery has no branches in the neck. Please remember, that's an MCQ. Internal carotid artery has no branches in the neck. External carotid artery has around 7 branches in the neck. So this is the bifurcation. In the posteromedial part of carotid artery, we have these bodies known as carotid bodies. Small carotid bodies are seen on the posteromedial surface. On the posteromedial surface of the bifurcation, we get carotid bodies on the posteromedial surface. If there is a, please remember, if there is a hypoxia, this hypoxia stimulates the carotid bodies and patient goes for tachypnea. And compensatory mechanisms acts to increase the oxygen level in the body. So therefore hypoxia stimulates the carotid body, and those guys who have persistent hypoxia will form hypertrophy of this body known as carotid body tumor. And who are those guys who have constant hypoxia? They are high altitude people and who else? And cyanotic heart disease patients. Cyanotic heart disease patients and high altitude people will have persistent hypoxia. Therefore they have carotid body tumor commonly. Please remember, this is therefore common in those guys. So this is one of the important predisposing factor. Hypoxia is one of the important predisposing factor. What are the other names of this? It is also known as chemodectoma. It is also known as potato tumor. It is also known as non-chromaffin paraganglioma. Non-chromaffin paraganglioma is other name. So these are the various names of carotid body tumor, and regarding the clinical features of this tumor, it is most common in middle-aged females. Middle-aged females will get this commonly. It is usually unilateral in nature. It is firm potato consistency is present. It is firm like a potato consistency, and on movement there is a sign. What is the name of that sign? That sign is known as Fontaine sign. Fontaine sign is you can move the swelling here in the neck horizontally, but you cannot move it vertically. Okay, only horizontal movement possible. Only horizontal movement possible, no vertical movement possible. So there is no vertical movement possible and only horizontal movement possible. This is one of the classical sign known as Fontaine sign. This is known as Fontaine sign. And please don't forget, this is a swelling present in carotid triangle. It is a swelling present in carotid triangle. And when you look for the pulsation, there is a type of pulsation seen. What is the pulsation? If you keep two fingers on the swelling, this will only lift the two fingers. Please remember, if you lift the two fingers, that is known as transmitted pulsation. Transmitted pulsation. There is one more type of pulsation. If this is a swelling, if you keep two fingers over the swelling will not only lift the fingers, it will also separate the fingers. This is known as expansile pulsation. Where will you get expansile pulsation like this? Like this. If you keep a finger, the swelling will have this pulsation. This is seen in carotid artery aneurysm. In carotid body tumor, it will have only this movement. This is transmitted pulsation. Please don't forget, there is transmitted pulsation seen in these cases. Okay, classically, there will be transmitted pulsation seen in these patients. And the incidence of this carotid body tumor is only 0.5% incidence. It has only 0.5% incidence. Please don't forget, and this can go for malignancy. Mostly it is a benign tumor, and malignancy can happen in around 5 to 10% cases. Malignancy is seen in only 5 to 10% cases, and METs is rare. There is no METs. Okay, there is no METs. And for just for super specialty level, there is a classification for this tumor known as Champlain classification. Just remember, there is a classification. There is a classification of carotid body tumor from vascular books. Type 1 will have less than 25% attachment. If this is an artery, the carotid body is attached only less than 25% to the vessel. So less than 25% tumor is known as type 1. Type 2 is having around 50% adherent. Around 50% adherent is 3. So 3 is around, it is encasing the vessel. It is encasing the vessel. It is around encasing the vessel. And it is, in fact, in case of malignancy, it may be infiltrating. So just remember, type 1 less than 25% adherent, up to 50% adherent is 2, and type 3 is encasing the vessels. So type 3 is the only case which will need resection of the vessel. Resection and prosthesis for carotid artery will be needed only for type 3 cases. Other cases, no need to resect the vessel. So please remember 1 and 2, no need to resect the vessel, only excise the tumor. Only excise the tumor is a treatment for 1 and 2. 3 will need resection anastomosis. So this is not PG level question, this is not Darren Bailey or Sabison, it is a super specialty question. Just know the name Champlain classification. Coming to the investigations of carotid body tumor. So investigation of choice to diagnose is by means of angiography. Angiography is the investigation of choice. You should never do FNAC or biopsy. It will torrentially bleed. FNAC or biopsy are highly contraindicated. Investigation of choice is angiography. Angiography will show the vessels getting splayed out like this. The vessels, instead of going like this, internal carotid artery and external carotid artery, they are splayed out like this. They are pushed out like this, and it is due to the presence of this tumor. This sign is known as high yield question for PG exam, Liar sign. This sign is Liar sign, 1000 times asked question. Okay, 1000 times asked MCQ. Please don't forget. There is a sign known as Liar sign, which is seen on angiography. That is the investigation of choice. Other investigations you can do are duplex scan. Duplex scan can be done to look for the vascularity of the tumor, but angiography is the investigation of choice. So as I told you, treatment is excision of the tumor is enough. Excision of tumor is enough. No need to do anything major. Just only excise the tumor. Only for type 3 cases, we need to resect the vessels. Resect the vessels only for type 3 cases. Otherwise, only excise the tumor with vascular control. With vascular control means we should be very much ready with the vascular clamps. With vascular control should be there by chance. For example, if you are operating and the carotid artery tears up, we have to apply the clamp in internal carotid, external carotid, common carotid, and we have to do repair. So that purpose we need vascular control. Okay, we need vascular control and excise the tumor. We have to have vascular control and excise the tumor. Type 3 cases, resect the vessels. Okay, resect the vessels. Complications of this operation. Complications of this surgery include some interesting complications I want you to remember. Most common nerve injured in this operation is what? Most common nerve injured in this operation is superior laryngeal nerve. The nerve commonly injured in this operation is superior laryngeal nerve is the most common nerve injured in this operation. And another syndrome which happens in this operation is first bite syndrome. First bite syndrome is a syndrome which happens in this operation in which the sympathetic nerves are damaged. Sympathetic nerves are damaged. Sympathetic nerves are damaged. So that is known as first bite syndrome. The sympathetic nerve supplying the area is damaged, and that results in parasympathetic reinnervation. So this is just opposite to Frey syndrome. Just opposite to Frey syndrome. In Frey syndrome of salivary gland, the parasympathetic is damaged and sympathetic overrides. Here the sympathetic nerves are damaged and parasympathetic overrides, and that results in a first bite syndrome. As you start eating or chewing, there will be pain in the neck. So that is another complication, first bite syndrome. Please don't forget the important complications are most common nerve injury, superior laryngeal nerve, and don't forget first bite syndrome are the complications of carotid body tumor. Please don't forget carotid body tumor is a high yield topic for your exams. So we have completed one solid tumor in the neck from anterior carotid triangle. Now I am going to the solid tumor in the neck, that is cervical rib. Cervical rib. It is a solid tumor, solid swelling in the posterior triangle. So cervical rib, to understand what is cervical rib, please remember, this is C7, this is T1, this is T2. So usually we have thoracic first rib comes from T1 like this bilaterally, and the second rib like this comes from here. And what happens in cervical rib is a condition in which there is a rib arising from C7 vertebra like this. It can be a partial rib like as I have shown here, or it can be a full cord like this. It can be a full cord, there won't be a rib, there will be a fibrous cord. It can be a fibrous cord, or it can be a partial rib which is not coming completely to the front manubrium sterni, or it can be sometimes full rib like this coming to the manubrium sterni also. It can be a complete rib also. So please remember, cervical rib is presenting in multiple forms. It can be only a fibrous cord, no rib at all palpable. It can be a partial rib, or it can be a complete rib. So this is variety of appearance of cervical rib. So whatever it may be, whether it is a partial rib or a complete rib. Even in partial rib, we have a fibrous cord attached to the manubrium sternum. We have a fibrous cord will be there. Fibrous cord is present in all conditions. Okay, that will be the one you should not forget. So the multiple varieties of cervical rib are there. So please remember, cervical rib is present in bilateral 50% cases. So cervical rib is bilateral in 50% cases, and it presents most commonly in young females. It commonly presents to hospital in young females who commonly come to hospital. Okay, 70% are females. So it is common in young to middle age females. It will be common in young to middle age. Around 20 to 40 years will come to hospital. More than 70% are females. It is bilateral. It is bilateral. Okay. So now I'm going to draw you one anatomy, which is very important anatomy. I'm going to explain you what is thoracic outlet. Please focus this anatomy. If you understand this anatomy, this question is nothing. So please understand, this is heart, and this is arch of aorta coming like this, arch of aorta coming like this. And from this arch of aorta, this is brachiocephalic trunk. This is giving common carotid artery like this, and this is subclavian artery coming like this. This is subclavian artery coming like this. So this is right side common carotid artery, and this is right side subclavian artery. Now I'm going to tell you one interesting triangle. That triangle is bounded by, let us assume this is the first rib. This is the first rib. This is first rib attached to the vertebra, first vertebra like this. So this is first rib. I'm drawing exactly the same way it will be. It is first rib like this. It is attached posteriorly to the vertebra number 1, thoracic vertebra, and from there it comes anteriorly like this. And above this first rib only subclavian artery is running. And now there are two muscles I'm going to draw which are attached to the vertebra. So this is scalenus anterior muscle, scalenus anterior muscle. This is scalenus anterior. Another muscle is scalenus medius. So please understand the diagram I'm drawing, very important. Scalenus anterior, scalenus medius. Scalenus anterior, scalenus medius, and first rib together forms a triangle. This yellow color is one triangle. What is the name of this triangle? This yellow color triangle is known as scalenus anterior, scalenus medius, first rib is known as scalene triangle. It is known as scalene triangle. What are the contents passing through this triangle means, first important point, subclavian artery comes into this triangle. Another thing which is coming out of this triangle is 1, 2, 3. What is this 3 which is coming out of this triangle? They are brachial plexus. Brachial plexus is seen coming out of this place. Brachial plexus is coming out of this triangle. Upper trunk, middle trunk, lower trunk is coming out of this triangle. So which is not there in this triangle means subclavian vein is not there in this triangle. So first rib, scalenus anterior, scalenus medius in this triangle, which is not a content means subclavian vein is not a content. Please don't forget this MCQ. So and this is known as thoracic outlet. This scalene triangle is known as thoracic outlet because the thoracic vessel is coming out of this triangle. The brachial plexus is coming out of this triangle. Now concentrate on this picture. I told you that is a cervical rib. The cervical rib is usually arising from C7 vertebra. If it comes like this, it will occupy this triangle. Please see the picture how it is occupying. If it is coming like this, it will occupy the scalene triangle and compress the scalene triangle like this. Either it is a rib or a cord or something, it will compress the scalene triangle and cause a syndrome known as thoracic outlet syndrome. That syndrome is known as thoracic outlet syndrome. The cervical rib coming from C7 will come into the scalene triangle and compress the triangle and cause thoracic outlet symptoms, thoracic outlet syndrome. It is also known as thoracic outlet syndrome or thoracic inlet syndrome, and we have two types of claudication pain now. So one is neurogenic thoracic outlet syndrome. Neurogenic thoracic outlet syndrome. Another is vascular thoracic outlet syndrome. So vascular thoracic outlet syndrome is due to compression of what? Subclavian artery compression. So the blood supply to the limb is disturbed by subclavian artery compression. Neurogenic thoracic outlet compression, there is a compression of CIT1. The lower trunk is compressed. Please don't forget, lower trunk gets compressed in this. So the neurogenic thoracic outlet, which nerve is compressed is CIT1, lower trunk ulnar nerve is compressed. The nerve compressed in this is CIT1, lower nerve is compressed. So please don't forget, there are two types of thoracic outlet syndrome. They are neurogenic and vascular. So vascular thoracic outlet symptom is more common in cervical rib. This is more common in cervical rib. Which compression is more common means in cervical rib, vascular compression is more common. So therefore, what happens when there is a vascular compression? What will happen? There will be claudication pain in the arm. There will be claudication pain. Claudication means, I hope you remember what is claudication. You'll be discussing in vascular surgery. As you start working, for example, in the leg, when you start walking, the blood supply to the lower limb decreases and get a pain and compels you to take rest. Same way, when I'm starting to work with my hand, for example, if I'm cooking or I'm playing shuttle or I'm writing fast, the blood supply to the upper limb will decrease because of the compression of subclavian artery, and I will have claudication pain and I will leave the hand down. So that is a classical clinical feature, claudication pain. In fact, many patients you can see ulcer in the hand, or you can even see gangrene in the fingers. Gangrene in the fingers. Ulcer, claudication pain, gangrene in fingers are also seen in many patients. So this is classical vascular thoracic outlet syndrome is due to compression of subclavian artery. And in neurogenic claudication, if the nerve is compressed, ulnar nerve is compressed, there will be pain along the medial side of arm and forearm. There will be pain along the medial side of arm and forearm. Pain along medial side of arm and forearm. Medial side of arm plus forearm. So these are the two types of claudication you should not forget. There are neurogenic claudication, neurogenic thoracic outlet syndrome and vascular thoracic outlet syndrome. And what is the nerve compressed is ulnar nerve. Please don't forget it is CIT1 corresponding to lower trunk is more compressed. Okay. Now come to the same picture. Now I'm going to tell you an interesting another symptom now. So one interesting symptom is, you all know there is a branch like this. There is a branch like this going up. This is a branch going up from the subclavian artery. It is going and supplying the circle of Willis in the brain. Circle of Willis in the brain is supplied by this branch. And this branch is known as vertebral artery. This is known as vertebral artery. Now because of compression by this cervical rib in this subclavian artery, what happens? The vertebral artery gives a collateral like this to the subclavian artery now. From vertebral artery, there will be a collateral developed to the subclavian artery, and that will be supplying the subclavian artery distally. So for example, if I'm starting to write or do some work with my hand, the blood flow to the brain will stop and the blood flow will divert to the hand. The blood flow to the brain will stop and it will divert to the hand. It will divert to the hand. What will happen? If it diverts to the hand, there will be giddiness and the patient will fall down. Will have syncopal attacks. This symptom is known as subclavian artery steal syndrome. Subclavian artery steal syndrome. The subclavian artery steals the blood of vertebral artery. Please remember that is known as subclavian artery steal syndrome is seen. In cervical rib, thoracic outlet syndrome, we have subclavian artery steal syndrome. And when you compress at the level of brachial plexus, you will have the shock symptom known as Tinel sign. So along the course of the nerve, you will have pain radiating when you tap it here along the brachial plexus. When you tap it here along the brachial plexus, you will have pain radiating along the shooting pain will be seen. That is Tinel sign positive. And at this point of time, you should know some test to bring out occult thoracic outlet syndrome. Tests for thoracic outlet syndrome. Because not all patients will come to you with the classical symptoms. Sometimes we have to bring out the symptoms by doing some test. First important test is Adson test. So please focus on me what I'm doing in Adson's test. So this is a video question asked in AIIMS. Ask the patient to extend the arm like this, turn opposite side, take a deep breath. Arm like this, extend opposite side, take a deep breath. What you should do as a clinician? You should palpate the radial artery. The radial artery pulse, the dynamicity decreases. That is Adson's test. Radial artery pulse, dynamicity decreases because of the compression. The dynamicity decreases as you ask them to turn opposite side. It is not pulse rate which decreases. The dynamicity, how the feel you have, the dynamic pulse becomes steady pulse because of Adson's test. So Adson's test, don't forget. Another test which is asked in exam is ask the patient to keep the hand like this and do continuously like this for 5 minutes. Ask them to do like this for 5 minutes. If they do like this, the blood supply to the hand will be lost and they will have claudication pain and they will put the hand down. This is known as Roux test. Roux test. Please don't forget, this is a video question came in AIIMS. Roux test. Then comes Hallstatt test. Hallstatt test. You have to ask the patient to stand in a military position. They should stand in a military position like this, with extending the shoulder like this. So that will cause pain. Standing in the military position itself will cause pain. So military position standing will cause pain. Okay, so please don't forget. Roux test is abduct the arm and flex the elbow and do this test. That is Roux test. So abduction of arm is very important. By doing these tests, by doing these 3 tests, we are naturally compressing by doing all these tests, we are naturally compressing subclavian artery and we are bringing out the occult thoracic outlet syndrome. So thoracic outlet syndrome diagnosed by these tests. So thoracic outlet syndrome is diagnosed by all these tests. So what are the investigations I should do now are, investigations to be done to confirm this is by means of X-ray. When you take, we can pick up the cervical rib. X-ray shows cervical rib, but it is not sufficient. We have to do CT thorax, and we may need angiogram. Angiogram should be done to look for subclavian artery compression. Subclavian artery compression, we have to do angiogram. CT thorax regarding the surrounding vessel compressions. To look for the surroundings before surgery, we need a CT thorax and neck. It is not only thorax, we have to do CT neck with thorax. So all these investigations you must do. And at this point, I want you to tell one important point, that is, the subclavian artery is this. As it is getting compressed by the cervical rib like this, it may develop because of compression, it can develop a aneurysm. Please remember, it can develop an aneurysm like this. So we can sometimes palpate the subclavian artery. Aneurysm is also palpated in many cases. Subclavian artery aneurysm can be seen because of compression. Okay, the subclavian artery aneurysm you should look for. Okay, this aneurysm can be seen, and always the cervical rib is palpated. Which place? It is palpated in the posterior triangle. In posterior triangle, where? Cervical rib is palpated in the posterior triangle. If this is the posterior triangle, this is clavicle. If this is clavicle, the cervical rib is palpated above the clavicle. This is the place. On the base of posterior triangle, just above the clavicle, you palpate a bony swelling. Even you may be having a bony swelling there without some symptoms. So please palpate and see whether you are having any bony swelling above the clavicle both sides. So cervical rib may be remaining occult in many people without any symptoms. They will be silently living. Please don't forget this point. So this is about the cervical rib. I hope you understood the 2 solid swellings we have discussed. Carotid body tumor and cervical rib you have understood so far. So next I'm coming to the next liquid filled swelling, branchial cyst, high yield MCQ topic for national board exams. For all national board exams, this is a favorite topic in this chapter, branchial cyst. Definitely they will ask you a question in this. It is a liquid filled swelling. Please don't forget, branchial cyst is a liquid filled swelling, and I hope you remember this image from embryology books. So 1, 2, 3, 4, 5, 6. 1, 2, 3, 4, 5, 6. There are totally 6 pharyngeal arches we have. Embryologically, in the fetal life, we have totally 6 pharyngeal arches. Which one disappear? Can you tell me which one will disappear? The 5th guy disappears on both sides. The 5th fellow disappears. And you all very well know the 2nd arch will come down and fuse with the 6th arch like this. 2nd arch will come down and fuse. And this is a pouch which is present in the congenital life, fetal life. This pouch disappears after birth. The 2nd arch comes down and fuses with the 6th arch, and the pouch disappears. If pouch persists, that is known as branchial cyst. That is known as branchial cyst. Persistence of the pouch between 2nd and 6th arch is known as branchial cyst. If the 2nd one comes and does not fuse, if it remains like this, there will be a cleft. Please remember, this is cleft. This cleft will remain as such in the post birth. That is known as branchial sinus. So remember, this is known as branchial sinus. So this fusion with the formation of pouch is branchial cyst, which will have no opening outside. Branchial sinus will have an opening outside. The 2nd to 6th arch not fused. The opening, external opening, where is it seen? Can somebody tell me where is the external opening in a branchial sinus, congenital branchial sinus? It is seen at lower third of sternocleidomastoid. Anteriorly. I will show you that image, don't worry. But please don't forget, the branchial sinus of 2nd arch has an opening in the sternocleidomastoid in the lower third. Over here it will be seen, there is opening will be seen. So branchial sinus opening is seen in the lower third of sternocleidomastoid muscle. Sometimes the first arch can also remain remnant. First arch remnant will have external opening in front of here. You have a preauricular sinus here. That is known as preauricular sinus. Preauricular sinus is first arch remnant. Okay, if it is a 3rd arch remnant, if the 3rd arch comes down and remains as a remnant, that presents as a opening above the clavicle, over the clavicle. In the clavicular region, we have a sinus. So which is common? First arch remnant is common, or 2nd arch remnant is common, or 3rd arch remnant is common. So what we are seeing in practice is most common branchial sinus is 2nd arch remnant. 2nd arch remnant is what we see in practice. So please remember, the first arch remnant will have opening in front of here. 2nd arch remnant will have opening in the lower third. 3rd arch remnant will have opening above the clavicular region or suprasternal region. It will be either in the clavicle or suprasternal region. Clavicular or suprasternal region you have opening. So please remember this. Now I will show you the patient. So this is the patient who is coming to you with a branchial cyst and branchial sinus. I will show you 2 patients. This is one patient with a branchial cyst and this is another patient with a branchial sinus I am going to draw. So this is the neck and this is the sternocleidomastoid muscle. Please remember, this is sternocleidomastoid muscle like this. And for this person, this is the sternocleidomastoid muscle like this. So to please understand, branchial cyst presents as a cystic swelling in the carotid triangle at upper third of sternocleidomastoid muscle. In the upper third of sternocleidomastoid muscle, branchial cyst presents as a swelling, cystic swelling. It is transillumination negative. Please don't forget, it is transillumination negative because it contains thick components, and very important MCQ, it contains cholesterol crystals. It is containing cholesterol crystals present inside. So it is present in the upper third of sternocleidomastoid. The swelling is cystic consistency. Transillumination is not positive, it is negative. Transillumination is negative for these cases. So the classical point is it is transillumination negative. And if you see the cyst is lined by, lining epithelium is what? The cyst is lined by squamous epithelium. Okay, it is a squamous epithelium. So how is the cyst formed? It is because of the pouch persisting between second and sixth arch. Between second and sixth arch, the pouch persists. That forms this cyst. Okay, it is located in the upper third of sternocleidomastoid muscle, and transillumination is negative. The contents are thick contents with cholesterol crystals. So please don't forget, this cholesterol crystal is an MCQ. Which other swelling will have cholesterol crystal? Means hydrocele will also have cholesterol crystal. Hydrocele also has cholesterol crystal. This is branchial cyst has cholesterol crystals. Another point you have to remember here is the congenital branchial fistula. Where I told you it will open. This is a congenital branchial fistula or sinus. Many times it is a sinus only. Many times it is not a fistula. It is seen in the lower third of sternocleidomastoid muscle. The lower third of sternocleidomastoid muscle, we get a congenital branchial sinus or congenital branchial fistula. This is known as congenital branchial sinus or branchial fistula. It is seen on anterior surface, lower one third. Now, if it is a fistula, where is the inner opening? 100 times asked MCQ. Inner opening is present where? In a branchial fistula. Where is the inner opening? Can you tell me? The inner opening is seen in the tonsillar fossa. In the tonsillar fossa. In the tonsillar fossa, where is it seen? This is tonsillar fossa. This is anterior pillar. This is posterior pillar. In the tonsillar fossa, this is anterior pillar and posterior pillar. And this is the tonsil. Where is it seen? Where is the inner opening now? More specifically, where is the inner opening? The inner opening is seen anterior to the posterior pillar. The inner opening is seen anterior to the posterior pillar. Please don't forget, it is seen here. It is seen anterior to the posterior pillar. Is the correct location. If you want to know the correct answer, it is anterior to the posterior pillar, it is seen there. And what is the lining epithelium? The lining epithelium of this sinus tract or fistula tract is ciliated columnar epithelium. Ciliated columnar epithelium. Okay, it is a ciliated columnar epithelium which is lining this. So now I want you to remember one important thing here. This sinus, it will go through one important landmark. It will go through one important landmark. Inner is tonsillar fossa, outer is lower third. It goes through the bifurcation of common carotid artery level. It will go through the bifurcation. It will pass through the bifurcation of vessel. So to remove this sinus, we need to put multiple incisions in the neck like this. Multiple step ladder incisions are needed. Multiple step ladder incisions are needed to remove it completely. To remove this completely, we should make multiple small incisions and track the tract up to the tonsillar fossa. So because it is very risky, it is passing between the major vessels like carotid artery and it enters into the tonsillar fossa, we have to follow it and remove it completely. So this is congenital branchial fistula or branchial sinus. Is there anything known as acquired branchial sinus? Is there anything known as acquired branchial sinus? Is there anything? Yes, acquired branchial sinus is a complication of what? It is a complication of the branchial cyst getting infected and ruptured. If you see here, this cyst gets infected and ruptured. That cyst gets infected and ruptured. That is known as acquired branchial cyst. Or sometimes the surgeon thinks it is an abscess and put an IND. That also causes acquired branchial sinus. So the opening is present in upper third of sternocleidomastoid muscle. So if a patient comes to you with a neck sinus opening, if a patient comes to you with the neck, there is an opening. If it is in the upper third, it is an acquired branchial sinus. If it is in the lower third, it is a congenital branchial sinus. Upper third or lower third, we have to find out. So and then we can find out where is the thing. Okay. So the investigation of choice for this branchial sinus is branchial sinus sinogram or branchial fistulogram is advised. Branchial fistulogram is advised for these patients. They should undergo this, and complete excision is advised for both cyst and sinus. Complete excision advised. Otherwise, there is no big MCQ. We have to completely excise both the cyst and sinus. So the point you have to remember is cyst is lined with squamous epithelium. Cyst is lined with squamous epithelium. The fistula is lined with ciliated columnar epithelium. So the other complications of this branchial cyst is apart from infection and rupture, it can also cause branchiogenic carcinoma. It can also cause branchiogenic carcinoma from the remnants. You can get branchiogenic cancer. Branchiogenic cancer can happen from the remnants, and this type of cancer will have squamous epithelium. It will have squamous epithelium. Please don't forget, it will have squamous epithelium. The branchiogenic cancer will have squamous epithelium. Okay, or it can also have columnar epithelium if it is arising from the tracts. So both epitheliums can happen if it is arising from these tracts like branchial sinus tract remnant. That sinus tract remnant can also cause columnar epithelial cancers. So please remember, branchiogenic cancer is one complication of branchial cyst. Okay, branchial cyst. Coming to the next lipid filled swelling, that is cystic hygroma. Cystic hygroma is a swelling in the posterior triangle of neck. Branchial cyst is swelling in the carotid triangle. Cystic hygroma is a swelling in the posterior triangle of neck, and it is common in newborn. Please don't forget, it is common in newborn. What is the age group of this guy? Branchial cyst is most common in which age group? Most common age group the patient comes to hospital will be around 15 to 20 years. So please remember, they commonly come to you at the age of 15 to 20 years. The common presentation is around 15 to 25 years they come to hospital. They come to hospital at around 15 to 25 years. So it is common in young age. Though it is a congenital cyst, please remember it happens only at 15 to 25 years. Though it is congenital, the common age group of presentation is around 15 to 25 years. So cystic hygroma is not like that. It presents at the newborn period itself. It presents in the newborn period itself with there's a newborn baby. Let's assume there's a newborn baby. They will present you with a huge cystic swelling in the posterior triangle, which will have excellent transillumination. Transillumination is excellent, positive, brilliant transillumination is seen. What is the etiology for cystic hygroma? That is a congenital sequestration of lymphatics. Congenital sequestration of lymphatics present. Congenital sequestration of lymphatics is present, and it presents in newborn period. In fact, it is the earliest swelling one can note in the human beings. Earliest neck swelling seen in human being is this swelling, because this can even present as obstructed labor. Obstructed labor is also seen with this guy. This guy can present as obstructed labor also. So please remember, this is very important, cystic hygroma. And cystic hygroma have a list of complications like number 1, respiratory difficulties for the baby. Respiratory difficulty can happen, and it can become infected and can cause, it can get infected, and it can spontaneously, resolution also is seen in many cases. Spontaneous resolution is also seen in many cases. So respiratory difficulty, infection, spontaneous resolution, everything is possible in these cases. So what is the management of these babies? Management of these babies who are having persistent cystic hygroma. Old conventional treatment is what? Olden days, the conventional treatment is they used to do conservative or functional neck dissection. Conservative neck dissection. For such a benign case, they remove all the neck nodes. For this benign case, they remove all the neck nodes. It is a major surgery, unwanted now, because now this is completely treated by new drugs like recently available drugs like injection sclerotherapy. By using injection sclerosant, this problem can be now solved using a latest drug which is a highly expected MCQ known as tisibanil. Picibanil is the latest sclerosant used for cystic hygroma, and other therapies which can be given are bleomycin can be injected. Bleomycin or Picibanil. Picibanil original name was OK432 was the original name. Now it is now known as Picibanil and approved. Bleomycin is another drug. Okay, so there is no use of radiotherapy or other chemotherapy. No chemotherapy or no radiotherapy useful for this case. Okay, if you remove it incompletely, it can go for recurrence. You should either remove it completely or we have to go with injection sclerosant management. Okay, cystic hygroma, please don't forget the word Picibanil. And now coming to the air-filled swellings, laryngocele. Air-filled swellings in the neck. First is laryngocele. So let me make you understand the anatomy in front of neck. This is thyroid cartilage. This is thyroid cartilage. This is hyoid bone. I'm not drawing it so perfectly, but this is hyoid bone. And this membrane is thyrohyoid membrane. Thyrohyoid membrane. And this is cricoid cartilage. And after that, the tracheal rings will start. Tracheal rings will start. So, and this is what membrane? What is the name of this membrane between thyroid and cricoid cartilage? So, this is cricothyroid membrane. So, please don't forget these two membranes. This is thyrohyoid membrane. Thyrohyoid membrane. This is cricothyroid membrane. And this is first ring, second ring, third ring, keeps going on like that. Now, I want to tell you some interesting MCQs based on this anatomy. So, laryngocele is nothing but weakness of the thyrohyoid membrane. There is a weakness in the thyrohyoid membrane, and the laryngeal mucosa comes out on both sides usually. It comes out both sides usually. Who will it come out? It will come out on people who shout and take class like me, or who do another from blowers, trumpet blowers. Those guys will develop this laryngocele. That is protrusion of laryngeal mucosa on both sides. If they keep giving high pressure, that produces laryngocele. So you would have seen some people when they are speaking itself, you can see some air-filled swelling coming and going. Air-filled swelling will come and go. That is laryngocele. So laryngocele is common among trumpet blowers. Please remember, it is a defect in thyrohyoid membrane. It can be a internal laryngocele or external laryngocele. It's mostly bilateral. It is mostly bilaterally seen. And this is a cricothyroid membrane, is the membrane through which we put emergency needle tracheostomy. In a trauma patients, emergency needle tracheostomy is inserted in this membrane, cricothyroid membrane. So just below the thyroid cartilage, you identify the membrane and put a needle. That is cricothyroid membrane. And tracheostomy is done with the level of second and third tracheal rings. By cutting the second and third tracheal rings, tracheostomy is done. So tracheostomy, we will have a separate topic discussion, but tracheostomy usually we will discuss in ENT, but still there are some points in Bailey and Lowe we will discuss later. So please remember, these are all certain points you should not forget. And laryngocele is a very, very important point. It presents as a swelling in the anterior triangle, presents as swelling at anterior carotid triangle. It is air-filled swelling. Therefore, when you percuss, it is resonant. It is resonant on percussion, and if you see, cough impulse will be present in these cases. Cough impulse will be present for these patients. Okay, so most prominent on asking them to cough, or by doing a Valsalva maneuver, you can see them more prominent. Valsalva maneuver, they will be very prominent. And it is, will it move with deglutition or not? So please remember, it moves with deglutition. When you deglutate, it will move. Like it. What are the other swellings which move with deglutition? Like thyroid swelling will move with deglutition. Laryngocele will move with deglutition. Subhyoid bursa will move with deglutition. Subhyoid bursa will move with deglutition. So thyroid swelling, laryngocele, subhyoid bursa will move with deglutition. What else will move with deglutition? Midline dermoid cyst. So this is a clinical question for final MBBS students. What are the swellings which moves with deglutition? Are thyroid swelling, laryngocele, subhyoid bursa, midline dermoid, and also thyroglossal cyst. Thyroglossal cyst also moves with deglutition. So treatment is, we have to resect the laryngocele, resect it and repair the defect. Repair thyrohyoid membrane. So resect that cyst and repair the membrane. Okay, by means of neck incision, you have to resect and repair the membrane. So in the last air-filled swelling which we have already discussed is pharyngeal pouch. So I have discussed this in esophagus chapter. So let me just tell few points for completion purpose here, also known as Zenker's diverticulum. So please remember, this is common in old men. It is common on left side. It presents as a posterior triangle swelling. It presents as a with classical clinical feature of dysphagia. They will have dysphagia and halitosis. And when you compress, the swelling reduces with gurgling sound. It is a false diverticulum. Please don't forget, it is a false diverticulum. It is seen in posterior triangle left side in old men commonly. And investigation of choice for this is barium swallow. It is barium swallow, and treatment of choice is diverticulectomy. Or else we can do endoscopic stapling operation. What is the name I discussed in esophagus chapter? That is Dollmann's procedure. So just I'm reviewing it. The main discussion on pharyngeal pouch or Zenker's diverticulum is there in esophagus. In detailed way I have discussed in esophagus. Just remember, Zenker's diverticulum or pharyngeal pouch, investigation of choice is barium swallow, treatment is diverticulectomy or Dollmann's procedure. That is a procedure known as endoscopic stapling procedure known as Dollmann's procedure. Okay, please don't forget this topic. So let me show you the images from this chapter now. So full of high yield MCQ points. So this is a classical MR angiogram showing you the tumor. Showing you a tumor. Before surgery we do this type of images. And please don't forget, this swelling is pulsatile but not expansile. Carotid body tumor is pulsatile. Transmitted pulsation but not expansile pulsation. It is only a transmitted pulsation. Please don't forget. So biopsy and FNAC should not be done, and this is a 100 times asked image based question. So 100 times asked image based question on Liar sign. This is angiography. Please don't forget, this is angiography. So just remember the name Chamberlain classification, and pre-op RT should not be given for carotid body tumors. Only we give post-op RT in malignant tumors. So for malignant tumors and incomplete recurrence, we can do radiotherapy. Okay, first bite syndrome, don't forget, it is due to removal of sympathetic nerves. And the thoracic outlet syndrome, I told you, this is a scalene triangle between scalenus anterior, scalenus medius, and first rib. And this is first rib here. Within this, we get a subclavian artery and brachial plexus coming out. So what are the other causes of thoracic outlet syndrome? I didn't tell you. The most common cause is cervical rib. So please don't forget, the most common cause is cervical rib. Other causes are long C7 process, abnormal first rib, abnormal scalene muscle hypertrophy, heavy breast and sagging shoulders like this, or heavy breast. And acquired causes include fracture of clavicle, fracture of first rib, some tumors, scalene muscle injury, previous surgery, soft tissue tumors, direct brachial plexus injury. These are all, though it is listed, nothing is asked in exam. Please don't forget, the commonest cause is still the cervical rib. So please remember the symptoms. The neurogenic symptoms are most commonly due to ulnar nerve compression. The vascular symptoms is due to subclavian artery compression. So you will have a post-stenotic aneurysm. Please don't forget they may have post-stenotic aneurysm, and these girls will be common in 20 to 40 years females. You can see an incomplete bilateral cervical rib. Incomplete bilateral cervical rib. And this is a classical picture of one of our patients when I was doing MBBS. This patient picture we had. This is a patient having a bony swelling here. You can note it very well. So this is a posterior triangle. In the posterior triangle, you can see the bony swelling because of subclavian artery compression. She is having gangrene of the fingers. This is a classical case cervical rib with thoracic outlet syndrome. Please don't forget this. So and don't forget subclavian steel syndromes. Don't forget subclavian steel syndrome. So branchial cyst is most commonly between the second and sixth arch, and you can see it is seen most commonly as a present as a swelling in the upper third of sternocleidomastoid muscle. Branchial cyst presents as a swelling in the upper third. This is one of our patient in the upper third sternocleidomastoid muscle. In the upper third sternocleidomastoid muscle. So lining is by squamous epithelium for branchial cyst, and for sinus it is usually a columnar epithelium. Sinus will have columnar epithelium, cyst will have squamous epithelium. So please remember, under general anesthesia we have to put serial incisions and operate. There are injury to all neck nerves. All the nerves are in danger during the surgery for branchial sinus, hypoglossal nerve, glossopharyngeal nerve, spinal axis nerve. All are at risk. See, we are putting small incision and removing the cyst. If it is a sinus tract, we have to keep tracking it up to the tonsillar fossa by means of multiple incisions. So you can see this is a congenital branchial fistula because the opening is seen in the lower third of sternocleidomastoid. Since it is in the lower third, this is congenital branchial fistula. Expected image-based question. So it is passing at the level of upper border of thyroid cartilage, and it pierces the superior constrictor of pharynx, and it passes through the common carotid artery and it enters inside. Please don't forget it enters inside the tonsillar fossa. So transformation is negative. It is filled with cholesterol crystal, and you can see this is the investigation. Branchial fistulogram from lower third, it is going and joining the tonsillar fossa. Okay. So this is an excision of tract by multiple serial incisions. So cystic hygroma is presenting as a swelling in posterior triangle and is associated with Turner syndrome and trisomy 21 and 18. So it can be associated with Turner syndrome, trisomy 21 and 18, and you can see the classical cystic hygroma. If you put light, it will be brilliantly transluminant. Cystic hygroma will be brilliantly transluminant. So other rare swellings are laryngocele. The swelling happens in the thyrohyoid membrane like this. This is a classical laryngocele. The fellow is having a laryngocele on one side, and if you take an X-ray, you can see the air-filled swelling here and here. Very lateral picture showing you air-filled swelling. So swelling moves with deglutition. Please don't forget laryngocele. So these are the important questions for your exams from neck swellings. I want you to memorize all these neck swellings full of high yield points, and you can get high yield image-based questions also from this chapter.